Hello and welcome to the Swallows Charity Head and Neck Cancer Podcast. Join us on a head and neck cancer journey, presented by Derek Luthwaite.
Hello everybody.
And Chris Curtis.
Hello everyone.
We'll be discussing everything that patients and caregivers need to know about diagnosis, treatment, and so much more.
I'm CEO of the Swallows Head and Neck Cancer Charity, and I'm also a cancer survivor for nearly 10 years now.
And I became a caregiver when my wife was diagnosed with mouth cancer, and it certainly put me on a journey that I never expected to experience during my lifetime. Hello everybody, and welcome to another episode of the Swallows Head and Neck Cancer Podcast. I'm Derek, and sadly, as usual, I'm stuck with my partner in crime, Chris. Hi, Chris. Chris is on mute. This is showing his technical inability. He responded to me.
I wasn't on mute. I've told you before, Derek, this is all about just setting the scene. So I like to act the dumb one. So that's why I've done that purposely. So Derek,
it makes me look better then.
Yeah, exactly. So, thank you very much for that, Derek. And welcome everybody to today's podcast.
Today we have a very special guest with us. I'm going to introduce you to him in a moment, but first let me just explain. We are going to cover the area of the cancer journey from discovery and then moving onwards through the journey. And the person we're going to be talking to today, you will never see, you'll never hear about, you'll never know about. This is a secret agent. This is the SAS of the medical head and neck cancer treatment pathway. And we're absolutely delighted to have with us today Dr. Ali Khurram, Senior Clinical Lecturer and Consultant Pathologist, who happens to be, and I'm really, really pleased about this, a patron of the Swallows Head and Neck Cancer Charity. Dr. Ali, thank you so much for joining us.
Thanks a lot for having me, Derek and Chris.
No problem. Hey, Derek, why have you not said all the initials behind his name?
I could, Chris, but there are thousands of them. So let me start the podcast today by asking Dr. Ali just to introduce himself briefly, top line, and tell us a little bit about what a consultant pathologist is and how they get involved in the discovery of head and neck cancer. Dr. Ali.
Thanks, Derek. So like you said, we are hiding. Well, I would say hiding in plain sight or hiding in the shadows, but in a good way. So unfortunately, the patients don't see us and we don't see the patients, but still we are a very, very important part of their journey. And my role as a consultant pathologist, or even at the junior level as a trainee pathologist, if someone else was training to become a pathologist, is to look at any biopsies and any sort of cancer specimens and any tumors that have been removed from the patients. And we do it in multiple ways. So first of all, when the specimen arrives to us, we actually look at it with the naked eye and try to see if there's anything obvious in it that we can see, describe it, how big it is, measure it in 3 dimensions, etc. And then we actually just make sort of fine slices of it and put it into little cassettes and color it. And then those colored bits of tissue get put on a glass slide. And what we do is that put that glass slide on a microscope, shine a light through that, and then in that magnified light, we can actually see every single cell within that piece of tissue. And our role is to determine, first of all, if there is cancer present. If it is present, what sort of features can you see? Can we predict the behavior? What it may or may not do? If it's been removed as the final treatment, are the margins clear? So that means have the surgeons removed it all, or does the patient need any further treatment? And in some cases, we also do certain special markers which tell us what may be the origin of the cancer or how it may be treated as well, which helps the oncologist as well as the surgeon. So that's sort of, in a nutshell, the role of a pathologist.
I understand, and that's a very brief explanation of the massive amount of work you do. I just want to clarify one thing before we move on. when the patient is having the biopsy taken, usually because of a meeting with either an oncologist or with a dental surgeon, even depending upon who's discovered it, and when they are called back to get either the good news or the bad news, depending upon what it is, I am guessing that oncologist or that dental surgeon is actually telling us effectively what you've told them to tell us. You've done all the background, you've put all the words together. They're just rapid. They're the face of what you've been doing, I guess.
Yeah, so basically they're reading our words. But I guess that's the job. They've got a patient-facing job. But whatever we write on the report, the words we write and the diagnosis we give, any scores of tumors that we give, that's the information that the surgeons or oncologists will actually use to convey to the patient.
So they get hold of that detailed information from you, and now they can start planning the type and course of treatment that they're going to be offering the patient, depending upon what type of cancer it is they have. Can I assume that at some point during this ongoing journey, you're involved in terms of the treatment pathway? I mean, I guess you don't just suddenly disappear off the scene when you've done the diagnosis.
Yeah, so you're absolutely right. So we're involved in pretty much every step of the way. So like you said, the first step is when the first biopsy is done. Mm-hmm. And like you said, pathology is very important, because if you just look at radiology, not always you can tell whether it's a cancer or not. So you actually need that pathological diagnosis to first decide what it is and then determine how to treat it. That's the first step. And the second step is when the patient, of course, is having their surgery, and when that specimen is removed, like I mentioned, and we give details of what we may or may not see. And then once the patient has had their main treatment, then they are still kept under sort of review for a few years. And during that time, any further biopsies that are done, or if there are any other suspicious areas that might be biopsied, also come to us. And every time something new comes to us from a patient, we always get the old ones out as well and look at them all together to see, has the cancer come back? Is there something in this which is a bit worrying? Is there a bit of pre-cancer? Can we help in any way and provide any information which may actually help decide the future treatment?
And this is real people doing this job. This is not a sci-fi laboratory hidden in the background or the underground car park of the hospital with super duper machines doing all this work. These are real people doing these tests and.
Yes, they are real people. There are labs behind the scene. Of course, all the staining and cutting of the tissue and everything is done in the labs, but they're not very sci-fi. Sometimes they might be actually in underground car parks, but yeah, they're not very sci-fi. So a lot of it is dependent on the human element. In the lab, there's like a lot of different technicians who are very actively involved. So pathologist is just one member of the team.
Yeah.
And there's hundreds of team members who actually all work towards one result that comes out for one patient.
I know Chris wants to pop in, but just before he does, one last question from me. There's sometimes there's a feeling of a delay, from the time the biopsy is taken. Why does it take, 10 days or 2 weeks or 3 weeks to get this information back? I guess that's just an uneducated and frustration on the part of the patient and the caregivers that are involved. They don't know what's going on in the background, and this is obviously the opportunity for us to explain to them that these delays they're not out of just nobody cares. There's a lot of work going on here. Yeah,
absolutely. And I'll assure you that the delays are hardly ever from the pathology side. So we are very strictly governed in how much time we need to sign out these cases and get the report out. And ideally, we like to, anything that comes to us within a week, we actually want the report to go out so the patient treatment does not get delayed. Sometimes things are not in our control, so there might be a delay in the specimen reaching us by the transport from a different hospital, or you may want to do different tests which are not available in your own lab, which means it's got to be sent somewhere else. The pathologist may want a second or a third opinion because it's not a straightforward case, which again can cause a delay. And sometimes we're even looking for genetic markers as well. Again, they sort of add on a little bit of time as well. So the delays are usually just to make sure that we get the diagnosis absolutely spot on. Great. And most of the time not actually related to the pathology of the specimen.
Understood. Chris, do you want to come in here?
Yeah, I have to say, Derek, when I got diagnosed, I remember them putting a needle in my neck and they took a biopsy. That's what I was told they were doing. And I honestly thought it just went somewhere in the hospital to a machine, and the machine looked at it and said, yes, it's cancer, or no, it's not cancer. And I honestly thought it was my consultant doing all that work. I never realized there's a whole department behind it. And I think since knowing Ali, you know, and every time you hear him speak, it's incredible that there's that whole team behind that never, ever, ever gets mentioned. And, you know, and when you get to 5 years and you cured the cancer, go back. You know, my question to you, Ali, is do you see those ones that are success that you've seen on the table, which is a biopsy? And do you ever see the success of the people that have gone through to survivorship? Because obviously that's the whole journey. Or do you literally have to, like somebody else told me, that they have to see it as a biopsy and not a person, because they're actually making the decision on someone's life. And if you see it as a person, you know, you're all human. How do you make that decision of saying someone's terminal? And, you know, that's a hell of a sword to have above your head.
Very, very good point, Chris. Most of the time, we don't really get the follow-up or how the patient is doing unless they're discussed at the MDT meeting. And the MDT meeting is where oncologists, surgeons, radiologists, everyone gets together along with the pathologist, and some updates may be shared there, and we may find out how the patient is doing. But most of the time, we don't get that information. The second point is really interesting, and I can see the pros and cons for both approaches. Like I tend to feel and think that I'm not looking at a piece of tissue and this is a person. Whatever I'm actually doing is going to affect the person. Because I think that thinking of it as a piece of tissue just detaches you from that main aspect, which is that you are actually going to play a role in this person's life by doing your bit. And of course, that should not cloud your judgment, because we can only describe or write what we see down the microscope. So we can't make stuff up, and we can't just go sort of off on a tangent and write things that are not relevant. A pathologist's job is to look at things, analyze them, assess them, measure them, and actually write that very sort of objective report based on what you're seeing. Because the whole point is, how can you help this patient?
You're listening to the Swallows Charity Head and Neck Cancer Podcast.
God forbid one of your family went through your hospital, would you be able to do a biopsy report on a family's tissue, do you think?
That's a very, very good question. I'm not sure if there's any restrictions on doing that, but ethically, I think what we have done previously, if there was a staff member or someone you knew was having a biopsy, that we step away and we let someone else look at it. So if it was a relative of mine or a friend of mine who had a biopsy, I will actually put my hands up, I'll declare that I know this person, and I'll let another pathologist report it, because then you get the real emotional investment in that. And I think the best thing is to let someone else have a look at it. That's the sort of principle we followed in the past. But if you're in a small department where you might be the only pathologist and you may not have a choice, what you can do is report it. And then you can ask a second person to blindly report it as well to see if they agree with you.
That's interesting, that, because I don't believe that I could divorce myself from wanting to know what was going on there. As soon as the paperwork was, I'd want to be checking it and double checking it, making sure that I agree with what's being said, even though I didn't actually conduct the pathology tests in the first place. I'd still want my finger in the pie, wouldn't you, Chris? Wouldn't you be wanting to stick your finger in and say,
I'm not that nosy.
Yes, you are. You are.
In a way, I can completely see your point, because I think my nature is that as well, because I feel like, I do so much for so many other patients and biopsies. And if it was a loved one or someone I knew, I really want to make sure that things were done absolutely right. But then, of course, you've got confidence in your colleagues as well, and everyone strives to have the same standard.
Do you know what? But before I obviously met Ali and another pathologist, I honestly thought the pathologist was that American program where they just go and look at dead bodies and suddenly, you know, they solve a murder. because they're a pathologist. I never realised, and to my ignorance, that actually they done the work that they do. I just thought you went out and looked at dead bodies.
You're showing your age here, Chris. You're showing your age. Talking about Quincy MD.
That's it.
That's not quite the same thing.
I think most people think that, Chris, because that's the general perception, and on TV as well, in shows, anytime you hear about the pathologist, it's about a post-mortem or an autopsy in that context. And the fact that we don't see patients, so the sort of profile is not very sort of visible. And that's definitely something that needs to change in pathology. And that's something that I'm very passionate about, to actually talk about pathology and tell people how much work goes on behind the scene, and for people to know how important it is.
Well, hopefully with this podcast will help with that, in terms of getting the message out that, there's a huge backroom staff making decisions about the treatment route, treatment pathway, the type of cancer it is. I also understand and believe that the pathologist is on standby during any surgery that's taking place as well, because not all cancer is treated with either just radiotherapy or chemotherapy or a combination. Often there is actual surgery involved, and I believe you guys are actually kept on standby during that. Can you explain to our audience a little bit about what you're doing there, Ali?
Sure. So yeah, we are on standby, not for all the cases, but the cases that are sort of more complex, and either the cancer has grown too much, or the surgeons are not entirely sure that they've got removed all of it. So in that case, they will call us and let us know, or tell us to be on standby. And then what happens is that while the patient is still on the treatment table, they remove the specimen, but from the borders of the specimen, they'll remove some more tissue. And that tissue, someone just runs upstairs with that tissue to us. We freeze it, and then we look at the frozen tissue under the microscope, and we get the result back within the hour while the patient is still asleep. And in that, we can tell them whether there is tumor in it or no tumor in it. And if there is more tumor, then means the surgeons, without waking the patient up and having another procedure, they can actually just remove a little bit more tissue. Whereas if there is no tumor, they can have more confidence and can start stitching things back and plan to actually finish the procedure.
That's amazing. So this is, you absolutely think that everything is being decided by the top guy in the operating theatre. He's got the music playing in the background, and he's shouting at everybody, and he's pass me this and pass me that, and he's digging away there. But in reality, even all that experience and knowledge, he needs the backup and support of people like your own department to say, you've missed a little bit, or you need to go a little bit further, or you've done a great job here.
Yes, and I think we're very complementary to each other. The surgeons and pathologists basically are part of the same team, and they can't work without each other. We need them, they need us, and it's just that complementary relationship.
And the patient needs all of you, of
absolutely.
Course. Chris?
So when patients hear people talking about margins, is that what you're talking about? Because a lot of patients will ring me up and said, I've just come out of the consultancy, and they start talking about margins. And the only margin I know is what you put down a piece of paper. So what they're talking about. So is that what they're talking about?
In a way. So that is also a margin, what I've just described, but that's what we call an intraoperative margin, which means that during the operation, we are telling them about the margin status. So margin means if this is your tumor, like you said, the paper margin, it's just like that. How far that tumor is from that paper margin, okay? In that case, we're just telling them when the patient is still asleep, whether the tumor is there, what they think is the margin. But once the specimen is removed and the patient is woken up and maybe even gone home, it takes us like a week or 2 weeks to get that whole specimen sorted. If there is bone in the specimen, it takes even longer because you have to soften the bone before you can make cuts into it. And then we look at all of those margins. We look at the lining of your mouth and where the surgeons have made their cut, and are all those margins clear. So we look at like 0.5 centimeter clearance. So the tumor has got to be more than 0.5 centimeter away from the cut that the surgeons have made, whether it's in bone and whether it's in the tissue in your mouth. And if that's the case, then we can say with some confidence the margin is clear, which means perhaps they can just keep an eye on you. But in other cases, it might be closer. It might be less than 0.5 centimeter, in which case we say the margin is close. And there's another situation where the tumor might be actually present at that cut surface or the margin, which means the margin is positive. and those patients probably need more aggressive treatment, either more surgery or chemo and radiotherapy pretty much straight away.
I just think it's amazing, isn't it? It blows my mind, Derek. It really does.
I don't know what to say. I mean, it's an investigation into minuscule pieces of tissue and looking at minuscule microscopic signs for whether we've got it or haven't got it, whether we need to do more, or, you know, I just find it unbelievable. And you don't have a clue that this is going on in the background.
No.
As a patient or a caregiver, all you ever see is what goes on in that meeting room upstairs with whoever you're seeing on the time. You have no idea that all this life-saving work is going on in the background for you.
Yeah.
You haven't got a clue.
And that's what, it's the same as radiotherapy, where I have a lot of people, they say, well, why is it taking so 10 days since I've got my mask fitted? It's because they're mapping out everywhere behind the scenes. And if they get one little margin wrong on the map out on radiotherapy, you can be paralyzed. But until you do what we do at the Swallows and talk to people like Ali and everyone else like we're doing on the podcast, you don't realize all this work's going on. You just see, like you say, Derek, that little team that is in your room, which is your CNS, the SLT, your consultant, and they're your gods. Yeah. But they've got their angels around the side of them that they can't do it without it. And I think I'm right. You know, that's why I work with Ali so much. I think we have to get this out to people, that they have to realize that there's people like Ali doing phenomenal work in the background. And you know, absolutely, and hopefully, like you say, this podcast will help that. So I ask one more question, Ali, and then I'll let the one that does all the talking talk again. When you take these biopsies out, surely that's a great opportunity to, I don't know whether you just throw them away or just send them off for research.
We tend to keep them. So, I mean, most of the biopsies become immortal in a way that we actually fix them in a chemical. So we cook them in a chemical which preserves in a lifelike state. And that's then sort of buried in a block of wax. So just paraffin wax, because you can melt it easily and it goes hard at room temperature as well. And in that form, tissue can just remain there pretty much forever. So we've got bits of tissue going back to 1960. So if we want, we can go back and get those old tissue out, get more slice from it. Sometimes the specimen is quite large, which means we can't sample at all or don't have to sample at all, in which case we try and take what we think is important and relevant, and then we save the rest for at least 6 months. And then when we realize and understand that we don't need any more of that, then it's probably destroyed. For research, it's a very good point. Ideally, it would be very good to keep all the tissue for research, but research is very sort of strictly governed with sort of ethics and approvals as well. And legally, we can't just keep the tissue unless the patient was involved at the stage when it was removed and gave consent for the tissue to be used for research. So you need to have an ethical approval in place in advance. You need to have a patient information leaflet. You need to explain to the patients that, okay, some of the tissue might be used for research. What would the research be? If they want, they can pull out of their research, etc. And all of those things need to be done beforehand, most of the time. Sometimes you can go and look at some of the tissues and apply for ethics retrospectively to just look at some biomarkers or any sort of things that you feel like may help patients in future, but you still need approval from the NHS and the governing bodies to be able to do that.
If we roll head and neck cancer forward 10 years, we don't know what's going to happen in 10 years, but the samples are being taken today could really form part of that research in 10 years' time. Why don't we just get it as standard that when we have an operation right across all the board, that when we're signing that consent form, that there's a paragraph about, can we use this in research today or whenever? Because, you know, why wouldn't you do that? I may not want to give you £10 towards research, but if you're going to take it out of my body, I don't want it back again. So, do you see what I'm trying to say? I just think it's a missed opportunity.
Yeah, I think you're absolutely right. I think because it's quite difficult to obtain ethical approval, and not many people have got experience with it unless you're research active. A lot of people don't end up collecting it, which means you may not have the resource. One resource that we do have is, of course, the biopsies and the tissue that we have sampled, so that will always be there if we wanted to go back. But having all of it or missing out on all of it, is a bit of a loss. But there have been some studies recently which have tried to bank some of the tissue just to see if it helps. And a few years ago, there was a big study led by Bristol. It was called Head and Neck 5000. And they actually collected 5,000 head and neck cancer specimens. And it's still available today. So if any researcher wants to go and approach them and ask for use of that tissue or DNA or anything else, then they can do that. And similarly, the government ran another project, which was 100,000 genome project, and which was analysis of 100,000 different genes from a wide range of different cancers, and just doing sort of DNA and molecular analysis. And that information is also available if people want to go and sort of avail that. But we don't have it available for every single case or every single patient.
Chris, were you asked if during your treatment at any point, were you asked if you would be happy to donate your specimens or samples or whatever it was they were taking for research purposes? Because I can absolutely tell you that Jane and I on Jane's journey, we were never even approached on this subject. And I like you, have to say, I think this is a huge opportunity missed. Huge opportunity missed.
Yeah,
what can we do about it?
Yeah,
I think some hospitals or some research active departments are actually very keen on biobanking. So I think in Liverpool are doing a lot of work for head and neck cancer patients, where pretty much all the tissue that they remove goes into a biobank, whatever is not used for diagnosis. But I think more people need to do that. But biobanking or getting approval of biobanking is not that straightforward, and it is sort of quite challenging. And I think people just need to have the will. I think once you've done one, then you sort of get more familiar with it. And I've obtained ethics for a lot of different research proposals for head and neck cancer work. And there are a lot of people who are willing to help and guide you along the way. So you're absolutely right. I think something's got to give to. I either need to have like a national resource or a lot more bigger teaching hospitals to have this resource if patients wanted to actually for these things to be sort of looked at, or even to help other patients in future if you wanted to go back and try a few things on a piece of tissue, or look for some new markers that you can target for treatment, or predict how a disease might behave. It would be very helpful.
I think every time we do a podcast with one of our professional friends like Ali, something comes out that is another challenge for the Swallows to take on. And, it's amazing that when you get these people on and you start talking to them, they're as passionate as what we are, Derek.
Yeah.
But sometimes their hands are tied where ours aren't.
Well, absolutely. And that gives us an opportunity sometimes to ask the blindingly obvious, but sometimes difficult question without any fear or favor, because we're not tied into the system. So, what are they going to say to us? What are they going to do to us?
Yeah.
You've already done it. You've already had my sample.
What you've described, something happened in America not so long ago where they collected a big group of sort of cancer specimens, and it's called the Cancer Genome Atlas, TCGA. And basically, it's a lot of different types of cancer. It's got about 700 head and neck cancers in it as well, which is just widely available to any researcher in the world. For anyone, you can just go and download that. You can just go and download information and just try and do research on whatever research you want to do on it. So the slides are scanned, and the DNA and molecular information is there. How did the patients fare? Did the cancer come back? Survival, everything is there. And it's such an amazing resource that you just think, I wish there was more of these.
Yeah.
The Swallows Charity Head and Neck Cancer Podcast is designed to help and support both patients and caregivers.
I just like to move along the pathway treatment just to a little bit further. So we've gone past surgery. We've heard about your department's involvement in the actual surgery side of things, and where and if you get involved. Now, what about somebody who's got a head and neck cancer that isn't and doesn't require surgery, and they're going to go either straight into either chemo or radiotherapy or a combination of the both? Are you Is the pathology department involved in that level area of treatment?
So I think we are. So of course the treatment wouldn't be given without the diagnosis, where we come in. So we give the diagnosis, and based on that, the initial treatment will be decided. And then most of the time, chemoradiotherapy, when they're given, you want to see whether the cancer has responded to it and the patient is doing better, or the cancer has shrunk in size or gotten bigger in size. And there are multiple ways of doing it. So the patient might have some imaging scans like a MRI or a CT scan or a PET scan. But sometimes it can be very difficult to determine these things on a scan, which means they might actually have a biopsy. Clinically, it may look like the patient has got what we call a recurrence, so the cancer has come back, or they're not sure whether it's completely gone away, and they'll do another biopsy, and that will come to us, and then we can actually tell them, oh, this actually looks like all dead cells, which means that your treatment is working and you can carry on, or this looks like cancer, which means it may have come back. So yeah, we are involved in it. Not every case, but quite a few of them actually do end up having a biopsy, just to have that sort of confidence in diagnosis and response to treatment.
And am I right in assuming that part of the work and the study that you do when you have the biopsy is to determine whether that cancer and that type of cancer is suitable for treatment by either chemo and or radiotherapy, or it needs a combination of the both? Or is that down to the oncologist to make that call?
Most of the time down to the oncologist. I mean, we do predict or mention a few things which can guide the oncologist. So for example, is the cancer attacking any of your vital structures? Is it, for example, we spoke about margins, then you've got a lot of nerves, and then blood vessels. Blood vessels supply nutrients to all parts of your body, and if the cancer gets into those structures, then it can travel to other parts of your body. And if we see that on pathology, then the oncologist is more likely to go for more aggressive treatments. The biggest problem with head and neck cancer is that there is no specific marker to head and neck cancer. Breast cancer is the survival and response to treatment has improved so much because things like the estrogen receptor and other specific markers to breast cancer can be targeted via specific treatments, and they respond really well. Head and neck cancer is it's a mixed bag. So there is nothing specific to head and neck cancer, and there's no treatment specific to head and neck cancer as well right now, which can actually just help this group of patients. Having said that, there are a few groups of emerging markers that may be helpful. So a recent marker, for example, we know about HPV, for example, okay? And to determine HPV, particularly if you got it in your tonsil or back of your throat, we look for a marker which is called P16. And basically stains the tissue brown. And if there is brown color in the tissue section, we tell the oncologist and the surgeon, yes, this patient is likely to have HPV, which means this patient may be more likely to have chemoradiotherapy than surgery, dependent on the size of the cancer. Another marker that's up and coming is PDL1, programmed death ligand it's called. And this is a marker which was known to express on our immune cells. And it's been quite successfully employed in melanoma and some of the other cancers, and lung cancer as well. But in head and neck cancer, only recently it's been licensed or approved for use. So right now in UK, we've got the guidance that any cancer that has come back or cancer that has spread to your neck or other parts of the body, we can do this PDL1 test on it and give a score. And dependent on that score, it may predict whether this patient is a good candidate to have that marker. And that's what the name that we use for it is immunotherapy. So you're basically tricking your immune cells into attacking this tumor. Because what the tumors do is actually they make all these immune cells, your blood cells, their friends. And they use them to their advantage and try to travel far in your body. And what we use is, this drug is to basically reprogram those immune cells so they can start attacking those cancer cells again.
And that is determined from the samples that you are testing right at the very beginning of the journey, or as we are going through? Can it change? Do you get different results as you're moving through the treatment?
Yeah, it really depends on the cancer. It really depends on the stage of the treatment as well. So yeah, and like I said, for different types of cancers, there are different markers and different treatments.
Okay, I think the wonderful Chris has got something he needs desperately to spit out to us all.
immunotherapy, I think, is an incredible drug that's come to market over the last 12 months. I think it's unbelievable. But I was at a big conference in Spain, and one of the company's medical directors, I said, I'm a thick guy, I'm a patient, explain what immunotherapy is to me and how it makes a difference. And the way he explained it to me was that if you take a cell, at the end of every cell, there's a triangle. And what you need to do then is a new good cell has the opposite triangle, and they get together, they mate, and you've got a bigger cell, and that's how in a normal body it all works well. But when you get a cancer cell, the cancer cell comes along, which is a bad cell, and it knows that it's a triangle, so he makes it a triangle, and they mate, and it kills that other cell, and so it goes on. But what he said immunotherapy does is it disguises your good cell as a square where it's really a triangle. So when immunotherapy comes along, it thinks it's a square, so it makes the opposite to a square so it can mate, but actually it's a triangle and it can't. And eventually that cancer cell will die. And he said that's the best way of explaining immunotherapy.
That's a very good way of explaining it, Chris. And another way of explaining it is it's like a Trojan horse. So it's basically tricking the cancers into thinking there's something else, and they eat them up or get close to them, and then they get killed.
Yeah. So you talk about markers, and we've got to assume there's people out there that be wondering what the hell we're talking about a marker. I understand what markers is because I've been doing this now for 8 years plus. Just explain briefly what a marker is, if you can.
So the simplest way of explaining what a marker is think about a marker as an antenna which is on the surface of the cell. So if you're watching TV at your home, you need good reception or signal, and you mount an antenna on the roof. And the marker on the cell is basically a similar sort of thing. It's sticking out of the cell like an antenna. And we can use special tests to actually determine whether that antenna is present or not, and how much of it is present there. And you can either block the signal or you can use the signal to your advantage for treatment.
But I've got this vision of this little piece of skin, or this whatever it may be, with a massive big antenna now sticking out of it, saying, "Hello, I'm here. Come and get me." And I'm sure it's not that easy.
It's not that easy because you can't see the antenna with the naked eye. So you actually need to use special techniques and methods first to unmask it, and then use these sort of techniques to actually identify it and make sort of like use a signal booster to actually visualize it.
Well, all I can say is whatever they're paying you, they're not paying you enough.
And agreed. And can I ask you a question, Dr. Ali? Are you doing anything unique or different to other pathologists and pathology departments around the country? Or is everybody who is diagnosed with a head and neck cancer and getting treatment for it getting the same opportunity for discovery and cure? Or is there a bit of a postcode lottery going on?
I think unfortunately there's a bit of a postcode lottery going on. Some people are getting a lot more access to a lot of these fancy new tests and treatments, and other people don't. It really depends where you are, what facilities you've got. I mean, one advantage of centralization, which means all the cancer patients being treated in one big hospital, is that at least in that region, everyone is getting similar treatment. I remember when I started training, Sheffield was treating Sheffield patients, but now we treat all the neighboring towns as well, because everyone comes here, pretty much everyone comes here for their treatment. So there is a bit of variability. In terms of the basic pathology practice and the information you're meant to give and guide treatment, we are governed by a sort of set of laws, if you like, and rules. So we have to provide a minimum amount of information. And then for that extra information or extra test, you may have to send it out to those specialist places and pay a bit extra for that service. So of course, COVID-19 has been one issue which has made quite difficult when people couldn't be in the same rooms. And because it's not just me reporting, I'm also training sort of juniors as well to become pathologists, so they can become consultants in future and report things on their own. So one big issue was not having trainees around and working closely with them because of COVID and all the social distancing, etc., which made it difficult. But one thing which has really improved over the last 10 years or so is digital pathology. which means you don't need to actually look down a microscope to diagnose things. You can actually scan a piece of tissue, just like you scan a document, and then you can just look at it on a computer and still do your diagnosis. So that's pretty much happening up and down the country. In terms of my own personal, because I'm also very sort of research active and very interested in finding new things that can help patients, I'm looking at a lot of different things, particularly not just the cancer cells, but also how the cells surrounding the cancer cells, which is like your neighbors or the environment of the cell, how they might be influencing the cancer cell. In some cases, it may be even more important than the cancer cells. And second, we are actually working on a few projects looking at artificial intelligence and actually how it can help the pathologist to get even more information from a piece of tissue and identify patterns that even a pathologist can't identify. So, I mean, all of us are using it on a daily basis. Imagine a life before Google Maps and Siri and Spotify and all these things. So what we're using is basically all of these sort of image analysis techniques in these tissues and identifying how many cells are there, the shape of the cells, how close they are to each other, a lot of different relationships. And then the good thing about AI is that it checks out these sort of quantitative numbers. It actually gives you numbers. There's nothing subjective or there's no guesswork with it. And those, what we've shown or sort of come across in our work, and we did a project on oral cancer recently as well, seem to be very useful in identifying patients or the risk groups of patients. For example, one project we did was we were looking at immune cells that were actually going into the tumor cells for mouth cancer. And what we found was that when we use AI, we can straight away, in a matter of seconds, not only identify that those cells are there, but also give a number for those cells. And using that number, we can straight away split the patients into a high risk and low risk group, which means that straight away for the high risk patients, you can give them more aggressive treatment. And that's at the biopsy stage. So there's a lot of things happening in the pathology world. But AI is, of course, one area which I think is very exciting and is going to definitely change things for the better.
I know one thing I've learned today more than anything else is that in the diagnosis and treatment of head and neck cancer patients, nothing would happen without the pathology department giving its input and its guidance and its steerance. And for that, I think we're all extremely grateful. Chris, have you got any other questions that you'd like to
I would certainly agree with that. But, you know, I always say, if you break your arm, you go in, you get it x-rayed, they put it in plaster from here to here, you stay in plaster for 6 weeks, they x-ray it, take it off, and you're fixed. Well, head and neck cancer, and I've spoken to a lot of patients, and I can't think of any two patients ever have had the identical journey. And I think now I understand why, when you're talking about, you know, the biopsy and the margins and everything else and the markers, if there's no one single marker that represents all head and neck, then you can't get one particular treatment or drug to deal with it, because our bodies are all different, unlike any other cancers, and it affects us all different. And now I'm starting to understand why. It all starts with that biopsy. And our bodies are all different, aren't they? So whatever's on that biopsy is going to be different to me, to obviously Derek, to you, Ali, to anybody else. And now I understand it a little bit more. So I thank you for that, definitely. So my last question, maybe, is why did you decide to accept patron of the charity? Because it's a big honour for us. You're one of only 2 health professionals that we actually have on there. Sorry, one of 3. Why did you accept it? You could have accepted any charity, but you accepted us, which is a great honour to us.
I think the honour is all mine, Chris. Honestly, I mean, I was really, really honoured and flattered when you asked me. And yes, you are right. There are a lot of charities out there, and I have worked with some of the other charities as well. But I feel like in terms of head and neck cancer patients, the work that you guys are doing and the caregivers and the involvement of the patients, the work that you're doing is second to none. I believe that Swallows is the best head and neck cancer charity and the biggest in the world. And it's obvious to see what difference you make to the patients. I've been to some of those patient meetings, and it's incredible. And I don't think any other charity is doing that. So unfortunately, I shouldn't use the word unfortunately, but most of the charities are being led by clinicians. And the focus of the charities and the approach is very different. And you're one of those few charities which are being driven by patients. And I think that's just so refreshing. And that is the important thing, that seeing your work on social media actually made me realize even more why my work is important. And when you asked me, I was just so thrilled and so honored. And I just couldn't wait to actually be a part and help.
Well, thank you for those kind words. I'd like to leave it there, but I can't. But thank you for those kind words. It is an honour for us as well. Looking at the training period for someone to do what you're doing, I honestly believe our trainees coming through are our game changers of tomorrow. Because I think once you are in your role and you're doing what you're doing, sometimes you forget to ask the question, why? But I think as a new recruit into any industry, never mind just health, but any industry, the first thing you start having to do is ask, why do I have to do that? Why do I do that? Because you're just coming out of college or university. So I think they are our game changers. So what's your thoughts of trainees coming through? How can we, from a patient's perspective, help them as a group? Because I do it with the dentists. We do a lot of talks with the dental team. And what period do they have to work at before they get to be such a great guy like you are?
Thanks for your kind words. Now, not so long ago, I was a trainee as well. So I think it's all a matter of where you train, who trains you, and also how much self-confidence you have as well. If you are in a big center and you're seeing a lot of different things, then of course you learn a lot more. So pathology is all about experience. The more different types of patterns you see, the more you learn. You were talking about earlier, every patient being different. And no single biopsy or piece of tissue is the same as the other. Everything is different. There's always something different. So that's, of course, one thing. So going to the medical or dental school, doing your degree, and then you have to do 1 or 2 years as a junior doctor, and then you have to train for 4 to 5 years as a pathologist. So you're looking at least 10 years worth of training before you become a consultant. That's probably the shortest possible
10
span
years.
of time. Yes. Mine was longer because I've never done anything the easy way in my life. So I decided to do a master's, and then I decided to do a PhD. And then I spent 2 years in maxillofacial surgery. So my training actually took 16 years. But I feel like that every single bit of training or those days actually helped me become the pathologist or the person that I am. Trainees, you're absolutely right, are a future. And I think the most important thing is for the senior staff or consultants who are working with those trainees and pathologists to pass on some of this enthusiasm. So most of the people that I've trained with or worked with were very good and good teachers and would share knowledge and experience and want you to do well. But there were other people as well who would just look at it as work that needed to be done, that needed to be finished, and to move on to something else. And I think that's probably one of the reasons why pathology has suffered in the past, is that people, because they are not patient facing, they don't feel like you need that sort of enthusiasm and drive, that sort of infectious sort of nature of yours or attitude to rub on to the juniors. And I think that is changing. So I think the younger pathologists that are coming through are all very enthusiastic and very engaged and very hands-on and very open to ideas and technology, etc. And we need to make sure that our trainees learn all those things. So for example, any second or third opinion or challenging cases that come to me, I always make sure that the trainee sees as well, because that's the biggest and best education that they'll get. And as a trainee myself, I learn more from those cases than anything else. So Professor Paul Spade, for example, who used to be a consultant here, very well-known name, and he used to get really, really difficult tumors from pretty much all over the world. And I would insist, and he would also make sure that I ended up seeing pretty much everything that he was seeing. And that's the best training that you can get, because otherwise you will be in a protected environment. You'll only just be seeing what's coming to your center, because pathology is so different. And it's really strange that you just go down south of England and different types of tumors are more common, and different parts of the world, the same tumor might look different. So, and it's very important to have all of those experiences, but also very important to engage with charities and bodies like the Swallows to actually learn and realize that there is a patient connected to this piece of tissue that they're reporting, and have sort of a human element to pathology. The thing that I can think about is, for example, any pathology meetings, and it's really sad because I've been to a lot of pathology meetings, but I've never seen a patient speak at any of those meetings. And once or twice I've even recommended that, and it hasn't been taken on board. But I think that's where we need to actually make sure that you guys are also part of what we are doing in terms of education and training. So trainees and young pathologists can actually see that and see how important it is to engage with patients and what it means to you. Because it's very easy to speak to another pathologist and explaining what you're thinking, but completely different to try and explain what you've seen and what it means to the patient and how it may affect their treatment.
So,
Absolutely.
So you're 16 years in training, which I think is unbelievable. Most people don't last in their jobs 16 years, never mind in training. So you are our game changer, because you've done 16 years training. You've come into the profession as a consultant now, fully blown, top of your tree, and you're making changes. And I would say that's because you've done exactly what you wanted to do throughout your training, is to push and push and push and learn and learn and learn. And then all of a sudden you've come in now, and I know the difference you're making in the land of pathology. So every credit to you.
Chris, I know you'd love to carry on talking to Dr. Ali forever, but we're running very short of time now.
Okay.
I'd just like to take this opportunity to say, Dr. Ali, thank you so much, for coming and talking to us today, and for explaining to us simpletons what the pathology side of head and neck cancer is all about. And we are ever so grateful that you chose to be a patron of the Swallows charity as well. So thank you so much for joining us today. I hope you found it a bit of fun, and we've certainly found it hugely interesting and informative.
Thanks a lot, and thank you, Derek, for your time, and for Chris for organizing this. It was just really interesting and good to talk to you. And when you ask me questions, it makes me think about things as well, which is sort of the best discussion that you can have. So it's not just a one-way thing. So thanks a lot for having me here and letting me be a part of this.
Chris,
at the same time, I was going to say that if people have got any questions or questions specific to their pathology, or feel free to just Google my name and drop me an email. And I'll be very happy to help anyone who feels like that they can use some help. Well,
that's a fantastic offer, Dr. Ali, but I think you probably opened up a floodgate there that you wish you'd not opened.
No, it's fine. We are here for the patients, and we can't help patients, and there's no point in us being here.
I can't see Chris getting off the keyboard for the next 3 hours now. He's going to be in there tapping away with all his questions and queries that he never got a chance to ask. Now,
I think what the Swallows does, though, is we've got an array of professionals like Ali, and patients do come to us on a serious note with questions, and it doesn't take me long to be able to put that out to my various different health professionals that we have, and we normally get a very good response from them.
I am absolutely convinced we've now caused a stack of biopsy tests to be queued up for Ali to get on with in the rest of what's left of today. Chris, it's time to wrap this one up.
Yeah.
Huge thank you, huge shout out, and thank you to Dr. Ali for joining us. You never know, we may ask you and invite you back again on another one, and we might get it a little bit more. Well, I'll try and do it without Chris, and then you'll get lots of sensible questions instead of all the nonsense that comes from him. Hey, Chris, guess what time it is?
Advert time.
Go for it, my friend.
So if you want to get in touch with the Swallows, our email address is info@theswallows.org.uk. Our website is theswallows.org.uk, and obviously you put all the W's in front of that. Our 24/7 support line, which I always say is answered by a caregiver or a patient, it's not a call centre, it's not a message service, 24 hours a day, 7 days a week, is 07504 725 059. And I've been asked to also put on, mention our Facebook page because people are struggling to find us, Derek. So I've now added this to the advert.
Anything to expand your part. I know what you're like.
I know. Well, just go on facebook.com and then put in the Swallows Cancer Support and you'll find our main page. We also have about another 7 or 10 pages feeding off that, but please go on that. And if you're on Twitter, just put in the Swallows group and follow us on Twitter. I think I've done the advert right.
Yeah. You've not had much practice, have you? But thanks for that. So once again, thank you, Dr. Ali. Thank you, Chris. Thank you for everybody for listening. We hope you found it informative and interesting. And we look forward to talking to you again on our next episode. Bye.
You've been listening to the Swallows Charity Head and Neck Cancer Podcast. For more information, please visit www.theswallows.org.uk. We hope you'll join us again next time.